The witness number 3 is going to testify to the relevance of posterior column injuries. What's a problem? What's an irrelevant little midnight bother?
So first of all, since it's yes or no, I'll say yes. So this is actually one of my favorite topics, and my residents could tell you that I stress these injuries like crazy. Spinous process fractures go between being totally benign to being a surgical indication that leads to a mess down the road, if missed. From my experience, many physicians are terrible at differentiating them, and this has to be one of the most common missed injuries that I see in my clinic that results in what could have been prevented with a one up, one down, and ends up with a full-blown corpectomy. And then sometimes you'll have simple spinous process fractures that don't even need to be followed up that end up with a huge surgery. And so when I evaluate my interns at the end of the year, I really stress these types of fractures. And I actually do kind of a whole court session where I just throw spinous process fractures at them and have them just tell me if they think they're stable or not. So thank you for letting me talk about this topic. And let's talk about good and bad actors and then an extra surprise at the end. So spinous process fractures are common fractures. They're also associated with other injuries. They may occur in isolations. They may occur as part of a distraction injury. They may occur as part of a burst fracture. And one is considered stable while the other is operative. And so I'll shift my view to the AO classification over here. And before I continue too much, I promise I'm not being paid by the AO. I just really like this classification, and I'll make references to it throughout my talk.
Interject here. Don't worry, there's no money in AO for that.
You know, I'm just a disciple of the truth. So when looking at the AO trauma classification, you see that your AO fractures are minor fractures and they include your spinous process fractures. You could just send them out, not follow up, and these patients do well. But then you have your type 2, your type B, which are your distraction injuries. And here you have your B1s and your B2s, which are your, when you have disruption of the posterior ligamentous complex. But I also want to, and your B1 being the transosseous fractures, the B2s being your flexion distraction injuries. And I want to stress that the difference between the B1s and the B2s is the B1 is a transosseous monosegmental fracture, while a flexion distraction injury has a combined osteoligamentous component. And this becomes very relevant later when we talk about different types of management and characteristics of these fractures. And then I want to also add the B3, the hyperextension type, because they are distraction injuries. They usually happen in a patient with pre-existing ankylosis. And if you kind of look at the severity of these fractures, they go from stable to sometimes stable to unstable, and I'm not covering the type Cs, but those are very unstable. And so I'm going to go into talk about a tale of two spinous processes. You've got the one on the left, you have these vertically oriented spinous process fractures, and then you have the one on the right that is a horizontal spinous process fracture. Here I'm going to kind of touch up on what we had discussed a bit earlier. I get called all the time being told that someone has a 3-column fracture. And to me, in this type of scenario, only a horizontal fracture is a violation of the posterior column, and the one on the left is not. And so sometimes you have a burst fracture with a laminar fracture, and people will call that a 3-column injury. And And you could have a patient that has a type C injury, which is a very different type of 3-column injury than your typical flexion distraction injury. So I really do think it's important to stick to the AO classification instead of just kind of bucketing everything in the 3-column category. And so going back to the columns, traditionally speaking, we have 3 columns to the thoracic and lumbar spine. The anterior consists of the ALL and the anterior 2/3 of the body. The middle is the posterior third of the body with a PLL. And then posterior is all the structures posterior to the PLL. The anterior vertebral body withstands axial load and compression. The posterior ligamentous complex is a tension band that resists forward flexion or kyphosis. But I also do want to emphasize over here that the anterior column does have some distraction stabilization capabilities when you talk about hyperextension injuries, and there is some load sharing on the posterior elements, but just we live our life in kyphosis, so the anterior column really sees mostly compressive forces, and the posterior column sees mostly distraction forces. So going back to these lovely block diagrams, you have your posterior column on the left, your anterior column on the right. The yellow line represents the tension band, and in the normal situation, when you have flexion force, the posterior tension band, the posterior column, kind of resists the forward flexion. Now, when we're talking about a transvariant fracture over here, we're actually talking about our B2s, and that's when you have a disruption of your posterior ligamentous complex, and you have your force come down and pop, you fall forward. The other version of this is your B1, which is your transosseous fracture, and that's when you have a fracture go only through the bone in one segment, and you have your force forward, and you have forward flexion, as you could see in this image here. And so when we talk about treatment for these injuries, generally speaking, since the failure is in tension and posteriorly, what you really want to do is compress the back and then secure it down with screws, and therefore you've restored the tension band. And in a traditional sense, the anterior column has not been compromised with an axial load, and so you're able to go one level above and one level below. And here in this injury, here you could see that there is some distraction in the back. You see a PLC injury up top, even though there is a A1 type component to it. As Ashraf mentioned earlier, these are usually stable, and so this could be treated with above and below, and due to the presence of the compression fracture at the middle level, I did not instrument it, although I think that's a possibility as well. And so I emphasize again, the goal is to recreate the tension band when it comes to these fractures. And so now I'll go into a few more examples. And so people use the term chance fracture all the time, and that's actually also one of my pet peeves, because a chance fracture is a very specific type of fracture. And it's almost come to the point nowadays that when someone says chance fracture to me, it's meaningless to me, because I'm not convinced that they are conveying the appropriate fractures, besides the fact that I think chance fractures are actually quite rare. And so it's a transosseous distraction injury through the vertebral body, pedicles, and spinous process. It's monoblock. And the reason this fracture type is differentiated is because it theoretically may be treated with bracing due to the large bony contact area that heals quite well. Bone heals well to bone. Ligamentous tissue does not heal that well. But in my hands, these fractures still get operative management because in my mind, it's equivalent of treating a mid-shaft tibia fracture in a cast. It is a theoretical possibility, but we don't really do that anymore. there are complications with it, and it limits mobility, and we just have no reason to do it unless there are special considerations specific to that patient. The more interesting variation to the flexion distraction injuries are the ones that are combined with your axial compression fractures. And as Ashraf mentioned before, he mentioned the A-type fractures that had B components. Now it's my turn to talk about the B-type injuries that have A components. And so over here on the left, you have an L1 B2 fracture. On the right, you have this L3 B2 A4 fracture. The one on the left gets a T12 to L2 instrumentation versus fusion, even though there's a bit of a compression deformity to that fracture. The anterior column is stable, so in my mind, you recreate the tension band, and then I evaluate the A component of that fracture and see if that's stable or not. And so that would get one above and one below. And then you have the fracture on the right, where I think that's a pretty unstable A4 fracture. And so after recreating the tension band, it either needs to get two above, two below, or it needs to have a corpectomy to restore the anterior column. So I'll talk about this simple example over here. This is a 19-year-old female whose status post a motor vehicle crash. She has this flexion distraction injury. It's probably one of the closer injuries that I've seen to a pure chance fracture, even though you could clearly see that it exits through the disc, but there's still a lot of bony contact over there. And so on MRI, it's very clear that she has an injury to her PLC. And so to me, this would be an operative fracture, no questions asked. However, this was not initially my case. And another provider decided to try treating it in a brace. As you can see over here, you still have gapping of the fracture. And so I will make a few points about bracing. I understand why one would want to brace this fracture. There's a lot of bony contact area. But if you're going to try to brace it, you need a hyperextension brace. And especially if you have a lower lumbar fracture, a normal Jewett or TLSO will not reach down to that level, and you would need a thigh extension, which is another reason I don't like treating these fractures with braces. Fortunately, I volunteered to adopt this fracture, and so I went and I did a percutaneous L2 to L4 fusion. You could see on the left over there, you could see that just with positioning alone, I was able to close down that fracture, and then I just went one above, one below, percutaneously fixed her. I did not fuse her. And so this is her immediate post-op. You can see the reductions there. Everything seems to be holding. And then 14 months post-operatively, you could really see how that pedicle has consolidated pretty well. She has maintained alignment. And to the people who advocate treating a lot of these with braces, saying that's motion preservation, I could take this hardware out right now, and she will gain her motion back. The difference is, in the meantime, this is kind of like an external brace. She was able to enjoy her life and not have to go around with a brace with a thigh extension, which is miserable. So going back to the tale of two spinous processes, the one on the left is non-operative. The one on the right is operative. I do want to take this moment to mention a non-spinous process type of injury, and that's a ligamentous B2. You can see on this image over here, you don't really have any identifiable fracture. If you look at the L2 vertebral body, you could say maybe there's a bit of a compression deformity, but if you look posteriorly at the L1, L2 interval, you see that there's actual gapping, as you could see here. So this is a flexion distraction injury that traversed only through the soft tissue, and so one really needs to take a close look at imaging. Now, as I said, things aren't always so simple. What do you do in this scenario? Is this horizontal or is it vertical? One could argue, could get out and measure the angles, but the reality is, I don't know. So how do we go and assess this? The other discussion that we like to have is MRI or uprights. Now, in this case over here, it's clear on MRI that the posterior tension band is gone, and this is a clear flexion distraction injury. However, what about this MRI over here? I see some signal in the back. I see some continuity. You could show this MRI to multiple people, and you'll have a whole discussion about whether the PLC is intact or not. That's why in the TLIX system, they have that special category called the undetermined, unknown. And so I'm a very simple person. I don't like the gray zone. And on top of that, there was this interesting study done by Vaccaro and his colleagues where they looked to see the association between radiologists' read on MRIs, and then when those injuries were taken to the operating room, they correlated it with the integrity of the posterior ligamentous complex. And the conclusion was the sensitivity and specificity of MRI for diagnosing PLC injuries are lower than previously reported in the literature. The integrity of the PLC as determined by MRI should not be used in isolation to determine treatment. And so that's why I like getting the uprights. Going back to this image over here, you have a bunch of vertically oriented spinous processes, but I want to prove to myself that it's stable. You get the uprights, the alignment looks good, non-operative. Here we have another patient. He's a 24-year-old male who was in a motor vehicle crash, and you kind of look at T11, T12, T12L1. There may be some gapping over there that are compression. It's kind of equivocal. You get an MRI. I promise you that the MRI will be as clear as mud. So I went to get the uprights, and looking at the uprights, you see that there's actual gapping between T11 and T12. It goes from 20 millimeters up to 30 and then back down to 25. And so this patient got surgery. And so since we've been talking about distraction injuries, I'm going to touch up on the B3s because they're often ignored and they are very bad actors. These are usually patients who have an ankylosed spine, whether it's due to dish or angst-bond, and these are highly unstable injuries. Any patient with an ankylosed spine who presents with neck or back pain has a fracture until proven otherwise. If no fracture is seen on CT, this is a case where I will get an MRI as long as they could fit in the MRI scanner. There have been multiple reports of these patients going into the MRI intact and coming out paraplegic. The reason for this is these patients are kyphotic. You put them supine on the MRI bed, then you have a tech who, after they can't fit in the MRI, tries to hyperextend them even more, and they get a spinal cord injury. And with that, I'd like to talk about this 85-year-old female who presented with this fracture to an outside hospital. It was initially read as a compression fracture, as you can clearly see. Here, she has osteoghost bone, so it's kind of hard to see the details of the fracture. But to me, this in an ankylosed spine and the fracture pattern looks like a hyperextension injury. So she was sent home. She came back a few days later, paraplegic. She had translation of this fracture. She had an injury to her spinal cord. And so we ended up taking her to surgery. Sorry, that's not her. We ended up taking her to surgery and fixing her, but unfortunately she had the deficits. Now, when we talk about these fractures, they are long fractures, and they actually behave like a long bone fracture, and so they have long lever arms. So you should not do less than 2 above, 2 below. My preference is doing 3 above, 3 below in these patients to help control that lever arm. It's like the basic AO fracture principles, where you want to get fixation close to the fracture and then far from the fracture to help control further translation. In addition, because these patients are usually kyphotic, and to reduce them, you want kyphosis, I place them on a kyphosing table, and this does a lot of the work for you. It's a bit more difficult to do these on your usual Jackson frame. And so my take-home points are: vertical spinous process fractures are usually benign. Horizontal spinous process fractures represent a B-type injury. When in doubt, obtain uprights versus MRI. My personal preference is our uprights. Have a high suspicion for injury in ankylosed spine with back pain, and B3 injuries in an ankylosed spine get longer constructs. Thank you very much.
So very nice lecture. Let me ask you again, does physical exam still matter? So we were always taught to rotate patients around and palpate their back. And I know spinous process fractures have pain, the others have pain, but does palpation and gap identification still matter? Is that relevant?
Yes, Your Honor.
So it is. So
Yeah.
do you routinely do that? Because that's one of the things that still drives me nuts when people tell me about a spinous process fracture or whatever, posterior element injury, and there's no palpation, there's no inspection exam.
Yeah, and I mean, I'll tell you, like some of these patients, they may have had a spinous process fracture in the past that just didn't heal. You get a CT, you see a fracture through the spinous process fracture. Sometimes that could tell you if it's an acute or chronic injury, for instance. And with an ankylosed spine, if there's an area in question, I will ask my residents if they had pain and palpation in that area, because that is a key part in my management of the patient. Because if I don't see anything on CT, but the patient is reporting back pain, that patient is getting an MRI.
Bob, what do you think?
And I think all of those points are absolutely great. My question is going to be, I love your discussion with the ank spondies, because that is so critical. I've seen the same thing that you have. They said, okay, yeah, you got back pain or everything's fine. They come back 2 or 3 days later, neurologically devastated. My question in that situation, would you ever consider, you've got these folks, they're kyphotic. You've got a fracture through that segment. Would you ever consider, in these patients, you're going to the operating room anyway, doing an osteotomy and correcting that kyphosis? Has that crossed your mind in certain situations?
It has crossed. I try not to mix deformity with trauma, but also, in all honesty, it's usually pretty difficult to get a perfect reduction on the table. So even when you fix them, they are a bit hyperextended. But I also figure they've been living their whole life like that. If it would have bothered him, they would have presented to me earlier for deformity correction, but they haven't, and I just want to put everything back home.
Their bone is kind of bad anyway. Do you ever consider augmenting your screws, even going 3 up and 3 down?
No, I don't augment. To me, that's a lock and plate construct. If I do have any concern, I'll put in more screws, but over here we're dealing with lock and plate principles.
Hey, David, question from here. Really enjoyed your talk. I was wondering...
This microphone.
Wow, I feel like Jens now. Hey, I was wondering, how do you make a decision whether to include the index level for, segmental fixation or not? I noticed that in a lot of segments, I think one pedicle might be, usable or not. So, I use every little bits of bone that I can get in my cases. So with other words, for example, the 3 level up and down, I think the pedicles, at least partially, were intact. And I was wondering how you make that decision.
So I think that's a fabulous question. And I'm a very simple person. If there's an intact pedicle, I will count that as a level. If the pedicle isn't intact, I may instrument it, but I don't include it in my calculation of 2 above, 2 below, 3 above, 3 below. With these patients, they're already fused. And again, the consequences of being wrong and underfixing these are catastrophic.
Shall we have a panel then to put this all together? I'll just be the moderator. I'll take your